fellowship in oral and maxillofacial radiology. She's a diplomat of the American Board of Oral Medicine and is currently working in Adan Specialty Dental Center. Please, Dr. Anwar, if you'd like to start.
Thank you for the introduction. Good morning, everyone. Thank you for joining me on a Saturday morning to talk about oral ulcerations and how we diagnose them and manage them. The reason I thought that this was important to talk about is because if you're currently practicing dentistry or seeing dental patients, you would have seen at least one patient coming to you with an oral ulcer. Maybe it's an incidental finding or their chief complaint. Either way, if you haven't seen these patients yet, I am sure you will soon. And this is because oral ulcers are the most common lesions affecting the oral cavity. Why is that? For a few reasons. Most of the conditions that affect the mouth will present as oral ulcers, things like lichen planus or herpetic gingival stomatitis, and they can be the manifestation of a lot of local or systemic diseases like infections, neoplasms, hematological, and drug reactions. In addition, they can result from different processes. So if we have a vesicle or a bulla, for example, that forms and then ruptures, the end result of that will be an ulcer. So we can see that coming up with a differential diagnosis is a key skill in clinical practice. Oops. So why is it important then for us to be able to diagnose and manage oral ulcerations properly or in an accurate manner? First off, because they can be actually the first presenting sign of an underlying disease like an autoimmune disorder or mucocutaneous disease. So you could be the first clinicians or providers to diagnose these cases in these patients. And then, as many of you know, I am sure, oral ulcers can be very, very painful. Pain is often the only reason that a patient will come to you or a provider to get the ulcer looked at. And sometimes they can't really see the location or describe the ulcer, but they will come to you complaining of pain. This pain can be so bad it can limit a patient's eating and drinking. Sometimes even drinking water can be painful for the patient, which is dangerous for them. And then a patient's quality of sleep can be impacted. It can cause them high levels of stress. So we can see overall that it does impact the patient's quality of life. This was an interesting study coming out of Ireland. They looked at different chronic mucosal diseases, and these diseases did include oral ulcerations as part of their manifestations and how this affected the patient's daily life. What was interesting here is that they did include the patient's own words when describing how they're affected by these ulceration or diseases. So let's take a look at some of those. So this patient said, you have to make a conscious effort to distract yourself, not let it take over your life. It can make you feel very depressed. I just don't go out anymore because it's so sore when I'm talking. I would be at the restaurant and I would be like, no sauce on that. It doesn't come in sauce, does it? It can be actually something that affects you that badly. It influences everything. If you make any plans to go out for an evening or for a weekend away, you would be praying. It wouldn't flare up on your face. It dominates your life. And this is really applicable to all patients. I've also had patients in my clinic who detail how hard it is for them to eat at restaurants or that they can't go anywhere without their medications, for example. So we can see how oral ulcerations and mucosal diseases can really affect our patients' quality of life. And unfortunately, there is a delay in diagnosis. This prolongs the time that patients are in discomfort, and this is also a source of frustration to the patients who don't know what their diagnosis is. So this is what some of those patients said. My dentist started treating me for thrush. In the end, I said, this isn't right, and he said to me, you know, everyone has something, just put up with it. Unfortunately, this is a scenario that we often see with our patients where they get prescribed inappropriate medications. This patient said, I went to the dentist, he was giving me lots of antibiotics. I went to the doctor, and he was treating me for fungal conditions. Again, we can see these patients getting misdiagnosed and prescribed inappropriate medications. I feel I wasted nearly 12 months of my life before I got a definite diagnosis. 1 year is a long time to live with something without knowing what it is. It's more manageable now, yeah, but I really resent the fact it took so long for me to get anything, any information, and to get any assistance with it really. So we can see the patient's frustrations not knowing their diagnoses. And this goes hand in hand with data coming out of the International Pemphigus and Pemphigoid Foundation. They saw on average patients saw 5 healthcare providers to get a correct diagnosis, 10% saw more than 10 healthcare providers, and on average it took patients 10 months to achieve a correct diagnosis. Ideally, we do want to see patients getting a correct diagnosis in a timely manner. It really shouldn't take them seeing more than 10 healthcare providers for us to get there, so hopefully this talk will help with that. Another really important reason we want to be able to diagnose and manage oral ulcerations correctly is because similar lesions can have different impacts on the well-being of our patients depending on the diagnosis. So misdiagnosis can have really serious consequences. In some cases, this can be fatal. And this is what I mean when I say misdiagnosis can have serious consequences. We can see here an example of two ulcers. They're on the same site of the tongue. They're both single ulcers. They're chronic. They can be indurated. They can present with a few symptoms. One of them, however, will resolve as soon as remove the source of trauma. This was an example of a traumatic ulcer. And then one can be fatal if we don't treat it. This was an example of squamous cell carcinoma. So we can see how misdiagnosis can really, really be fatal for some patients. Okay, so let's get into it. Say that you have a patient coming to you with something that looks like this, maybe a nonspecific appearance of an ulcer. It could be one ulcer, multiple ulcers, anywhere really in the oropharyngeal area. Maybe it's on the gingiva, the buccal mucosa, the tongue, the labial mucosa. What's the first thing that we do when we have a patient coming to us with something that looks like this? We ask them a lot of questions. The thing with the oral mucosa is that a lot of lesions clinically look similar, and it's really hard for us to diagnose just based on the clinical presentation. And this is the information that we need, or the questions we ask our patients the first time they come to us with an ulcer. We want to know how long they've had the ulcer to determine is this something acute or is this something chronic. If it's of a more recent type of onset, this goes with something acute. If it's for a more extensive period of time, this goes with something chronic. We do consider ulcers lasting these 2 weeks to be acute and any ulcers lasting more than 2 weeks to be chronic. And then we ask the patients how many ulcers are present. Is it single, like oral cancer, for example, or is it multiple like an infectious reason, for example? Sometimes the clinical picture does not match what the patient has gone through, so they may come to us at a time where the ulcers have already healed. But then when we ask them the questions, they say, oh, I've had 5 or 10 ulcers at a time. So we do make sure to ask this question to our patients. And then we ask them for the location. We want to know, is it non-keratinized or unkeratinized mucosa? We ask the patient, was there a bubble that popped before the onset of an ulcer? This is helpful because it can indicate a vesiculobullous condition or disease. We don't really use the word blister when we ask our patients just because they won't be familiar with that terminology. So we just ask them, was there a bubble beforehand? We ask them, have they had that episode before to determine is this primary or recurrent? And then we want to know, are there lesions anywhere else on the body for us to determine, is this something just localized to the oral mucosa, or is this something more widespread affecting the genital, the skin, the ocular or nasal mucosa? And then based on that, we can come up with our differential diagnosis. So for acute oral ulcers, if it's a single primary ulcer, it's either infectious or more likely traumatic. If it's a single recurrent ulcer, it's recurrent after stomatitis likely. For multiple primary ulcers, infectious or after stomatitis. And then for multiple recurrent ulcers, infectious RAS, or then we start thinking, could there be an underlying disease process like Behçet's, Crohn's, or ulcerative colitis? We can also think of EM. For chronic oral ulcers that are single, it's either infectious like a deep fungal infection, and we do have some concern for malignancy in these cases. And then for multiple chronic ulcers, it's either infectious in the immunocompromised patients, or we think of our immunological conditions like lichen planus, pemphigus, pemphigoid, and lupus. I'll talk a little bit about viral infectious oral ulcers because you are likely to see these in your clinical practice. So there are a wide spectrum of viral infections that can affect the mouth. In most cases, though, they'll only cause something short-term and local, like a herpes simplex infection in a healthy patient. But then we have infections like EBV, Epstein-Barr virus, or HIV, which can cause significant orofacial disease, which can impact our patients. Specifically, I'll talk about HSV1 because, again, these are the cases you will more likely see in your clinic. So the transmission, as we all know, is contact with infected fluids, usually saliva or lesions, and then this gives us disease of the mouth and the surrounding skin. So HSV2 is transmitted genital-to-genital contact. You'll likely see genital lesions, but HSV2 can cause oral infections, and HSV1 can cause genital infections. In both cases, they will cause an initial primary infection, and then later on a secondary infection that tends to be less severe in some, but not all patients. For the clinical presentation, and typically we do see these in our pediatric patient population, the patients will get this within 1 to 2 weeks of getting the virus, then the mouth gets affected. Initially, the clinical features are non-specific, so we see things like fever, malaise, and lethargy, and then this is followed by eruption of widespread ulcerations of the oral mucosa and the gingiva. This was one of my patients who came to me. He was a 25-year-old gentleman, and he complained of severe pain inside his mouth. He did say he had fever a few days prior. While he doesn't typically fit our patient population, just keep in mind that a primary herpes simplex infection can happen in all ages. And these are what the ulcers can look like. They're usually superficial, small and spherical, but then some can coalesce like we can see here, and giving us larger, irregularly outlined ulcers. Keep in mind that the ulceration can occur on any oral mucosal surface, the gingiva included, like we can see here. The gingiva becomes swollen, erythematous, ulcerated, with the ulcers affecting both the free and or attached gingiva. These ulcers can be really painful, causing patients difficulty to speak, difficulty swallowing, sometimes even drooling. We can sometimes also appreciate bilateral cervical lymphadenopathy in these patients, and sometimes they can come with a rash. And then we have a secondary HSV-1 infection. In this case, we can see recurrent intraoral herpes here and then here. This will present unilaterally with vesicles and ulcerations. So a lot of the time, the patients will come to you with secondary disease without really remembering that they've had the primary disease. Remember that the primary disease happens in childhood, so if you were to ask the patients, they might not really remember that they've had this. This doesn't really rule out a secondary disease. And then the secondary disease can also affect the vermilion lips of the border. I'm sure everybody knows this, herpes labialis or a cold sore, but it can also happen anywhere on the perioral or the perinasal skin. So how do we diagnose and manage a HSV infection? The diagnosis is typically based just on the clinical presentation. We can confirm this with PCR, but usually we reserve this for immunosuppressed patients or when there's some confusion regarding the diagnosis. For the management, the signs and symptoms usually will spontaneously resolve within 1 week to 10 days, but in immunocompressed patients, this can be more severe and prolonged. Patients, especially children, should be encouraged to stay hydrated and drink fluids. And even though the symptoms are really bothersome for the patients, treatment is primarily targeted at just symptomatic relief. So we can use things like topical anesthetic mouth rinses or gels. We can consider systemic analgesics, NSAIDs like ibuprofen or even paracetamol. And then we have TB, which is a bacterial infection. Luckily, the oral manifestations of TB are uncommon. Most commonly, you will see these on the tongue, but any oral site can be affected. The presentation is non-specific, so this isn't really particularly diagnostic just for TB. But when the index of suspicion is low, there could be a delay in diagnosis just because of this non-specific appearance. And this is how they present as. We can see an indurated, ill-defined ulcer with a hard necrotic base, and you'll see it covered by a sort of yellowish pseudomembrane. This is one here on the ventral surface of the tongue, and then this is one here on the lateral tongue. Then we have syphilis, a sexually transmitted disease. We've been seeing a lot of these cases recently in our clinic, but this is a lecture for another day. Primary syphilis will present as a large painless ulcer called a chancre, but just because of the way the bacteria is transmitted, it will usually cause genital lesions. But in 10 to 20% of the cases, the oral mucosa can be affected, like we can see here, and then on the dorsum of the tongue as well. Oral ulcers can also be a manifestation of systemic fungal infections. Usually, though, we will only see these in the immunocompromised patients, like aspergillosis, for example. It usually affects the perinasal sinuses, but can also cause ulcerations intraorally. And then we have mucormycosis. Again, it usually affects the arteries, but can also cause necrosis and ulcerations intraorally. The clinical appearance of these actually can mimic squamous cell carcinomas, so most of the time we do need a biopsy to get to a diagnosis. I do want to talk about reactive oral ulcers too, because ulcers resulting from trauma, these are probably the most common type of ulcers you will encounter in your clinical practice. And these represent a large group of conditions. It could be mechanical, trauma, self-inflicted, or drug-related. We diagnose these just based on the history, the clinical presentation, and identification the source of trauma. Most traumatic ulcers will have an obvious cause. They tend to be acute, single, they last maybe 2 to 3 weeks, and then as soon as we remove the causative factor, they will heal. So that's the management, just identify and remove the causative factor. This was one of my cases. She was also a young lady. She came to me complaining of pain inside her mouth. She saw different healthcare providers, and some of them were concerned with the appearance of this ulcer, but when we took the history, she did identify a source of trauma shortly before developing this lesion, so we diagnosed her with a traumatic ulcer. Then this was a case of Dr. Dalal Nu'mar. This was an elderly patient who also came to her with what was diagnosed as a traumatic ulcer. So keep in mind that chronic trauma can result from sharp edges of teeth or prosthesis and ill-fitting denture, for example, sometimes self-inflicted, especially in patients with psychological or psychiatric problems. Most commonly, you will find these traumatic ulcers on the buccal mucosa or the labial mucosa, for example, but they can occur anywhere else, like we can see here on the palate. And this is the presentation of what a chronic traumatic ulcer looks like, just for you to be able to recognize these in your patients. You will see an area of erythema and covered by a sort of yellowish membrane, and then this is surrounded by a rolled hyperkeratotic border. So again, central ulceration and then peripheral keratosis. This is indicative of a traumatic ulcer, especially chronic traumatic ulcers. Then we have thermal lesions. These are also common. In most cases, these are caused by close contact by the source to the oral mucosa, especially of the palate, particularly if it's something like a hot food or drink, especially if it's been heated in a microwave, and especially with a pizza. This is what's called a pizza burn, very typical for this kind of lesion. Chemicals can also cause oral ulcerations, including dental materials like hydrogen peroxide or whitening gels, local or systemic medications like aspirin, mouthwashes, and recreational drugs. This was also one of my patients. He initially came complaining of dental pain. He decided to go with a home remedy and use some herbs, pressed it firmly against the gingiva, and the result of this was a traumatic ulcer. So we do ask our patients not to do this. Moving on to immunological conditions, there are also common causes of oral ulcerations, things like RAS, lichen planus, pemphigus, pemphigoid, and EM. Although ulcers can be a distinctive features of these, they are rarely, with the exception of RAS, they are rarely the only presentation for these conditions. They're usually part of a more complex picture with other manifestations. Like in lichen planus, for example, we can see white striations. We can see blisters in pemphigus and pemphigoid, and then lip crusting in erythema multiforme. Additionally, we can see extraoral sign as part of these manifestations as well. So papules, for example, in lichen planus, also skin blisters in pemphigus and pemphigoid, and then the classic target lesions associated with erythema multiforme. I do want to talk about recurrent after stomatitis because it is actually the most common ulcerative disease of the oral mucosa, and the recurrent oral ulcers that happen in other diseases like Behçet or celiacs, they look exactly like this, so we can't really differentiate them just based on the clinical or even histologic examination. SIRAs occur in otherwise healthy individuals. They don't have any signs or symptoms of disease. It is confined to the oral mucosa, specifically the non-keratinized mucosa, so the buccal mucosa, the labial mucosa, the ventral tongue. The age group affected are our 10 to 19-year-old patient population, and then it gets less frequent with advancing age. Unfortunately, we don't really know what causes RAS, but we know that there is a genetic factor or component to it. And this is the typical clinical presentation of recurrent after stomatitis. We see round to oval shallow ulcers of the non-keratinized mucosa, like here on the upper and the lower labial mucosa, covered by a yellowish pseudomembrane, and then surrounded by this characteristic erythematous halo. This is a nice table summarizing for you the differences between the three clinical presentations of recurrent aphthous ulcerations. We have minor aphthous ulcers. These are small, they last about 2 weeks, they don't scar, and they make up the majority of ulcers. Then we have major aphthous ulcers. These are bigger, they take longer to heal, they do scar, and they make up 10 to 15% of ulcers. And then we have herpetiform ulceration. These are smaller than minor ulcers. They also last about 2 weeks, they don't heal with scarring, and they make up 5 to 10% of cases. And this is a good thing because herpetiform ulcers can be multiple. Patients can have up to 50 or 100 at a time, which, as you can imagine, is really bothersome for our patients. And this is a clinical presentation of those ulcerations. So we can see here a major aphthous ulcer on the palatoglossal arch. Major aphthous ulcerations, though, can involve other sites, including keratinized mucosa, like the dorsum of the tongue, the palate, and even the gingiva, so just keep that in mind. Then we have minor aphthous ulcers. We can appreciate the difference in size between this ulcer and that ulcer. And this is an example of a herpetiform ulcerations. Again, just because they're so small and they're multiple, some of them might coalesce together and give us rise to larger ulcerations. Sometimes patients may come to you saying they have a burning or tingling sensation before getting the ulcers. Sometimes they can see just localized erythema as well. They may say that things like crunchy, spicy, or acidic food can increase the pain. So how do we diagnose recurrent aphthous stomatitis? Generally, we do this just through the patient's history and clinical examination, but in some cases, we do want to rule out other conditions. Things like local factors like trauma, nutritional deficiencies, any sensitivity to gluten, SLS, which is commonly found in oral hygiene products, and any food sensitivities. Systemic diseases as well, like anemia, Behçet, Crohn's, ulcerative colitis, HIV, cyclic neutropenia, MAGIC, and PFAPA syndrome. So when do we want to diagnose the patient with just a localized form of FRAS, and when do we want to rule out any underlying systemic conditions? If a patient has a systemic sign or symptom, if a patient developed these ulcerations during adulthood, or if they developed this during childhood, but then they noticed it's been getting worse recently, that's a sign we start thinking, could there maybe be an underlying disease process going on? For the management of RAS, unfortunately, there are no internationally accepted guidelines on how we treat these, even though they are one of the more common oral disorders. There have really not been enough randomized controlled trials just to determine the best treatment, but we do have options available for our patients. And our main goal here is we do want to reduce the frequency of the episode and to control the pain as well. So we reassure and we educate the patient, and then it depends on the frequency, the size, and the number of lesions as well. In some cases, maybe the patient isn't having that much pain, it's not really affecting their everyday to-day life, we may not treat these patients. And for patients who have only occasional episodes, small lesions, maybe just 1 to 2 outbreaks a year, we can then consider just over-the-counter topical medications like protective emollients. These will provide a barrier for the ulcer, so it will protect them from noxious stimulants. Some of them also have active compounds in them, which will give them an immunomodulatory effect, which will also alleviate the pain. And then we can use just topical anesthetic gels or rinses or different mouth rinses too. For patients, though, who come to us with more frequent episodes, maybe more severe episodes, we can treat them with topical corticosteroids just to shorten the duration and the size of the ulcerations. They're effective, especially if we use them in the early stages. Sometimes, though, the ulcer is large, maybe it's slowly healing, not really responding to our topical corticosteroid or medication, then we can consider using intralesional steroid injections. Keep in mind, though, that topical therapy alone will not prevent the formation of new ulcers. Maybe it's not enough for patients who come to us with major aphthous ulcers, for example, those who have frequent episodes, those who have severe episodes, not really responding to topical medication. Then we can consider systemic medications for these patients. And these are examples of the systemic medications we use in our oral medicine clinic to treat those patients. We can consider using just a short course of systemic corticosteroids. This is really rarely indicated for long-term use because of the serious side effects that come with it. Colchicine is one of those medications prescribed in Behçet. A lot of the medications prescribed for Behçet primarily target the underlying systemic disease, but some, like colchicine, have been found to be effective for the oral ulcerations as well. So we do consider this even in patients who don't have Behçet's disease. Pentoxifylline is another option. It's been shown to be effective in decreasing the number and the size of oral ulcers, and then pain reduction with that as well. We can use dapsone, we can use azathioprine. Thalidomide is actually the most studied medication for oral ulcerations, but unfortunately it does come with side effects like teratogenic defects and then irreversible neurotoxicity as well. Plus, the effect of this tends to be temporary, so as soon as the patient stops the medication, the ulcers do tend to come back. We don't really use this in clinical practice anymore, but I thought I'd include it for the sake of completion. I didn't go into too much detail with regards to the dosages and how you should prescribe these medications, because ideally you do want these systemic medications to be prescribed by specialists who are comfortable with using them. But these are some of the side effects associated with those medications. So colchicine can cause painful GI symptoms, diarrhea, male infertility. Dapsone can cause methemoglobinemia, especially in patients with G6PD deficiency. We don't really use levamisole. Pentoxifylline can cause nausea. And then thalidomide, like I just mentioned, teratogenicity, polyneuropathy, and mood changes. There are actually guidelines for the management of oral ulcers, specifically in patients with Behçet's disease. Again, remember that the recurrent oral ulcers that happen in RAS are really indistinguishable from those that happen in Behçet's. And we do actually have quite a good number of patients with Behçet's in our region. So these are the most current guidelines. These are set forth by the European League Against Rheumatism in 2018. And if I can point your attention to the mucocutaneous involvement part of the guidelines, they do recommend topical measures like steroids for the treatment of oral ulcers, and they recommend colchicine for the prevention of the recurrence of oral ulcers. And then only in a select patient population do they recommend systemic medications like thalidomide. They do include that on their list: interferon alpha, tumor necrosis factor alpha inhibitors, or apremilast. Apremilast is actually an interesting drug. This was one of the fairly recently approved drugs by the FDA, specifically for the treatment of oral ulcers and Behçet's disease. It's a phosphodiesterase 4 inhibitor. It has been shown to cause a reduction in the number of ulcers and pain, and the side effects are generally well tolerated, things like diarrhea, nausea, and headache. And unlike some of the medications that we just talked about, there is actually good evidence supporting the use of apremilast, specifically for patients with oral ulcers and Behçet's disease. This was a randomized, double-blind, placebo-controlled trial. This was a bigger one. It was multi-center. There were about 10 countries involved, and they saw 200 patients in this trial. And we can see here that there was a reduction in the number of ulcers from week 1 all the way to week 12, and then this was paralleled with a reduction in oral pain as well. So we can see here the percentage of patients who were ulcer-free by week 6, and then they continued to be ulcer-free for 6 more weeks, was 30% in the apremilast group compared to just 5% in the placebo group. And then the median time for ulcer resolution was 2 weeks in the apremilast group compared to 8 weeks in the placebo group. And then the percentage of patients who were completely ulcer-free by the end of the trial was 53% in the apremilast group compared to just 22% in the placebo group. So really encouraging results. So while there is really no gold standard treatment for how we manage recurrent afterwards ulcerations, we do have a number of medications available to us in use. In practice, though, topical therapy usually is sufficient and efficient for our patients, but we always do risk-benefit, we weigh the risk and benefit when we decide, do we want to treat these patients with systemic medications? But like I said, usually topical therapy is sufficient. Only in select patients do we go on to consider systemic medications. When do we biopsy ulcers and when do we not biopsy ulcers? Generally speaking, for recurrent afterwards ulcers, we don't really biopsy them unless we want to exclude other disorders like, for example, Crohn's, sarcoidosis, or vesicular Bullous disease. Why is that? It's because anytime we biopsy an afterwards ulcers, the results will be non-specific. Histopathology will just show us a mixture of acute and chronic inflammation. So basically, if we have an ulcer and we send it to the lab will give you a report saying the patient has an ulcer. They won't really tell you the patient has recurrent after stomatitis or the patient has Behçet's disease. So biopsy may give us non-specific results in ulcers associated with Behçet's, traumatic ulcers, RAS, any ulcers associated with anemia, nutritional deficiencies, and EM. And what I mean by this is when you have a strong clinical impression or diagnosis of these diseases, that's the time that the biopsy may not be helpful. So if you have a suspicion for Behçet's disease, a biopsy won't be helpful. If you diagnose a patient clinically with EM, if you were to take a biopsy, the biopsy really won't provide you any additional information. So just biopsy when you're unsure of the diagnosis or you want to rule out any other conditions. I do also want to talk about lichen planus because it is the most common mucocutaneous disorder affecting the mouth. We do see these often in our oral medicine clinic too. This was one of my patients. He presented with really the classic oral lichen planus presentation. We can see a reticular symmetrical pattern on the buccal mucosa. Typically, these do tend to be bilateral. The signs and symptoms of this really range. Either the patient is completely unaware of the lesion, they're asymptomatic, or they can have really severe pain, burning, and sensitivity of the oral mucosa. I bring up lichen planus because the atrophic and the erosive forms both can cause oral ulcerations with varying degrees of discomfort. This was one of my patients. She was, I think, 10 years old at the time of diagnosis. She's the youngest person I've ever diagnosed oral lichen planus with, but this is what her tongue looked at, and this was sensitive and causing her pain. So we can see oral ulcerations and erosions of her tongue here. This was another one of my patients. We can see an ulcer on the buccal mucosa. And this is what I mean when I say that these ulcers in these conditions are part of a more complex picture. We can see here white plaques on dorsum of the tongue. We can see reticulations and hyperkeratosis and erythema as well of the buccal mucosa. So for these patients, the number of ulcerations really vary. It's not just one size fits all. The size varies, the location varies as well. So how do we diagnose and manage lichen planus? If they're just classical lesions and the patient also comes to us with classic skin lesions, we can get away with just a clinical diagnosis, but we do often need a biopsy just to determine or to confirm the diagnosis, and if you want to rule out things like dysplasia or malignancy. And then management really depends on identifying the etiology because some drug reactions or dental materials have been shown to cause lichenoid reactions. It depends on the clinical presentation, the patient's symptoms. Won't go into detail just because these should be seen by specialists, but we have different topical and systemic medications that we can use. Pemphigus vulgaris can also affect the oral mucosa. Also, won't go into too much detail, but it is one of those vesicular Bullous disorders where we can have vesicles and bulla rupture inside the mouth giving us oral ulcers. This was one of my patients, and in his case, his actually first presenting sign or symptom of the disease was his oral lesions. So he came complaining of pain inside his mouth. We saw ulcers and erosions of the palate. We saw some on the tongue as well, and he was diagnosed with pemphigus vulgaris. This was another one of my patients, but she came to me already diagnosed with pemphigus vulgaris. They just wanted us to manage her oral lesions, and we can see here these commitive gingivitis. Mucous membrane pemphigoid as well can cause ulcerations and erythema. We can see an ulcer here of the buccal mucosa. We can see an ulcer here of the tongue. So when you see these ulcerations, these are really non-specific in appearance, and that's why we really need biopsies in these cases for us to get the diagnosis. So we do need 2 specimens for histologic examination to get to the correct diagnosis. I won't plus or minus blood testing. I won't go into too much detail again with the management because these patients are seen by specialists, but it depends on the severity, the site of involvement, and any contraindication to systemic medications. And of course, we can't talk about oral ulcers without talking about oral cancer. So oral cancer can appear anywhere from something flat, slightly raised, completely exophytic, white, red, mixed red-white lesion. They can also appear as endophytic or even as solitary ulcerative lesions. This was one of my patients. Unfortunately, by the time he came to me, it was a bit too late. After we did the biopsy and diagnosed him with squamous cell carcinoma, he did pass away shortly after that. And his was a story that we do see repeated often in our patients where they get prescribed antifungal medications. He went to several healthcare providers. They were giving him different mouth rinses and ointments, and he was feeling no relief. Again, by the time he came, it was a bit too late. This was another one of my patients. He did come on time, fortunately for him, so he was able to get his treatment. And this is why it's really important for us to be able to recognize the features of malignancy and not miss the diagnosis of these cases. So what are the features of malignancy, or what are the red flags and things we look out for that can make us start thinking, could this be oral cancer or a malignancy? Any ulcer really persisting for more than 3 weeks, and the non-healing characteristic of that ulcer is a really important feature of malignancy. So anytime we have a single ulcer, we do want to rule out any source of trauma. And after that, if it's still non-healing and if it's chronic, we start suspecting malignancy in these cases. Any ulcer with a rolled border really should be palpated, because if we were to palpate it and we were to find that there was induration on palpation, this is also really suggestive of a malignancy. So rolled margins and an induration, these are really the most significant features of malignancy. And then really anything with an exophytic growth with surface projections as well. In terms of symptoms, just keep in mind if it's in a pre-ulcerative stage, the patients may not complain of any symptoms, or they may just have some non-specific discomfort. But then once the ulcer appears, it will start causing them more persistent pain, and this can radiate to the adjacent regions. Late symptoms will include things like reduced mobility of the tongue if it's affecting the tongue, or dentures that don't quite fit properly. For the diagnosis, of course, a history, clinical examination, biopsy, this is the gold standard of diagnosing oral cancer, and then imaging just to assess the spread of the disease. So as dentists, we really should be able to diagnose oral cancers just visually through our comprehensive examinations, and not forgetting to palpate the lymph nodes of the neck as well. Management is complex. It depends on things like the type and the stage of the cancer. So to wrap things up, this is a really nice decision tree which can help you come up with your differential diagnosis whenever a patient comes to you with oral ulcerations. So remember, before you start coming up with your differential diagnosis, there are key pieces of information that you need during your history taking that will facilitate you coming up with your diagnosis. So you want to know, are the ulcers acute, are they chronic, are they recurrent? If it's acute, remember, is it a solitary ulcer, are there multiple ulcerations? For a solitary ulcer, this is usually traumatic. For acute multiple ulcers, usually they are infectious in nature. And then for our chronic solitary ulcers, remember, either a deep fungal infection, or we do have some suspicious of squamous cell carcinoma. And then for chronic multiple ulcers, usually there's an underlying systemic disease, usually autoimmune, like pemphigus vulgaris pemphigoid, or also maybe lichen planus. And then for recurrent ulcers, whether they are single or multiple, it's usually RAS, or then we start worrying about any underlying systemic disorder, like cyclic neutropenia, Behçet's, or things like celiac disease. Thank you.
Thank you very much, Dr. Anwar. And if anybody has any questions? Yes?
Assalamu alaikum. Good
Excellent.
morning, Doctora.
Morning.
Doctora, where do you put the certain disease in the classification of ulcer? And I'm wondering what's your differential diagnosis about major ulcer with a pinpoint bleeding, not a massive bleeding like major erosive now. Pinpoint bleeding. Thank you.
So for your first question, it really depends on the presentation of the ulcerations. Usually, especially in our patient population, we have seen things with nutritional deficiencies show up as ulcerations. For example, iron deficiency anemia, or even deficiencies in vitamin B12, ferritin, folate. All of these can indicate ulcerations. Like I mentioned, things like Behçet's disease, celiac disease, all of those underlying systemic diseases can show up with ulceration. It's just a matter of identifying if the patient has any other systemic sign or symptoms, and then depending on the blood test or the workup that we order for the patient. As for major afterwards ulcers with pinpoint bleeding, either this ulcer has been traumatized, and we do see these sometimes in our patients, especially based on the location. So things like the lower lip or the buccal mucosa, patients sometimes can bite on these. And then for some cases, we do want to exclude bleeding disorders anytime we do see pinpoint hemorrhaging or petechia anywhere else in the oral cavity. Yeah. Yeah, it could be just major afterwards ulcer that has been traumatized by some reason. But keep in mind, for the base of the tongue and the oropharyngeal area, sometimes we do need our ENT colleagues to take a look, just because as oral physicians or dentists, we are limited in what we can see of this area. So scoping the area can be helpful for these patients too.
Crohn's disease.
Okay, yeah, so Crohn's is actually one of those well-known diseases that can cause ulcerations. The patient definitely needs to be worked up, especially if he has symptoms. But keep in mind, just because the patient does not have GI symptoms or signs does not rule out oral disease, because sometimes the oral manifestations can precede the GI manifestations. So the patient may have Crohn's actually.
I think I need to show you some photos
Yes,
about
Yeah.
I'm collecting some data about
Sure,
a patient with major ulcers. All of those patients with a GIT problem.
Yeah.
And I saw that phenomenon with a major ulcer with bleeding. So
Interesting.
I'm going to show you some.
Yeah, please. I'm really interested to see these pictures. Thank you.
Any more questions?
Yeah, just one question. Thanks so much for the presentation, doctor. Just one question regarding the adult that had primary HSP infection. So what kinds of questions did you ask this patient? And in our culture, are we reluctant to ask some specific questions? For example, if they had like a sexual contact, for example, and if you did ask these questions, do you find patients are more reluctant to answer these kinds of questions?
Yeah, that's a really good question. For the herpes simplex patient, the questions I asked were the ones I went through when I said, what are the questions we need to ask our patients? So the onset, was it acute, was it chronic? He said, no, it's been these 2 weeks. And then I asked for any systemic signs or disease involvement, and he said, I've had fever a couple of days. And I think at the time he had some lymphadenopathy as well. So the acute nature of the disease plus the clinical presentation. I could see ulcers not only on the labial and the buccal mucosa, but also on the lip. Add on top of that the gingival involvement. His gingiva was really erythematous. So all of those together come to give us something that is infectious. Again, he also saw healthcare providers, and there was some confusion regarding the diagnosis because he's 25 years old, and you don't typically see these in 25 years old. But to keep in mind that they can happen really in all ages. Adults can get them too for the first time. So the erythematous gingiva, the appearance of the ulceration, and the nature of the onset all can help you get to a differential diagnosis. As for the sexually transmitted diseases, you don't ever shy away from asking these questions because it can really help you with your differential diagnosis, especially with patients, like I said, with syphilis, and we have seen a lot of these cases in our clinic. I'm not really too shy in asking them about their sexual relations because it can help you come up with that differential. I wouldn't ask this question for a person who I'm suspecting of herpes simplex virus 1 infection, but rather for these sexually transmitted diseases like syphilis, for example.
Thank you very much, Dr. Anwar. And this is a small token of appreciation. Okay, so now we'll invite our next presenter, And we have 5 minutes, so we can have some coffee while we're waiting. Okay, we'll start our next session. So our next presenter is Dr. Fatma Al-Hindi. She is a graduate of Kuwait University, and then she went on to pursue her oral medicine degree in the University of
Pennsylvania.
Yes, sorry, thank you, Dr. And she has a master's in oral biology and is a diplomat of oral medicine. She is currently working in Farwaniya Specialized Dental Center, and she is about to give us a lecture in jaw pain and oral medicine. So please, Dr. Fatma, you have the stage.
Thank you, and thank you all for being here in this oral medicine lecture from the oral medicine lecture series. And also, I would like to thank the KDA for inviting me for the second year to give a lecture in this event. So today we are going to talk about an important topic, which is jaw pain. I have nothing to disclose in this lecture, and the main objectives are to familiarize oral healthcare providers with the role of oral medicine specialists and when to do the appropriate referral, and to discuss some of the non-odontogenic orofacial pain conditions, their pathophysiology and clinical manifestations, and also to be able to work in a multidisciplinary team that includes medical and even dental providers. So Sir William Osler is the father of modern medicine. He is a great diagnostician, and he is the one who established residency programs. In the old days, medical students used to study medicine in lecture halls, and he brought them from lecture halls to bedside clinical examination. He said that medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from the words heard in the lecture room or read from the book. See, and then reason and compare and control. But see first. This emphasized the importance of taking good history and performing good clinical examination, as they are the golden standards for any medical diagnosis. So you know that oral medicine specialist is trained and to manage and diagnose various oral conditions, including oral mucosal disorders, precancerous, cancerous lesions, orofacial pain conditions, among others. So because of the complexity and variety of cases the oral medicine encounters, he or she should work closely with other specialties, such as rheumatologists, neurologists, GI specialists, ENT specialists, among others. This is because most of the conditions these providers see will have oral manifestations. So for today, we have 3 patients. They all have the same complaint: my jaw hurts. So of course, these are AI-generated pictures of the patient with the same ethnicity, age, and gender of our real patients. So these are all real stories. The first one is 79 years old male, presented with left jaw pain, headache, and also left facial and neck pain that radiates to the left arm. The second one is a 32 years old male, presented with right jaw pain with earache and difficulty swallowing. He had several consultations with ENT specialist and endodontist without reaching any diagnosis. Our third patient is a lady. She's 18 years old female. She has right jaw pain with difficulty opening the mouth with occasional right earache. So let's start with our first patient due to seniority. He's 79 years old, and he has left jaw pain, headache on the left side, and also changes in vision in his left eye. Also, he has left neck pain that radiates to the same arm on the left side. So here comes the importance of taking good history. This is an example of good history taking, especially in non-odontogenic orofacial pain conditions. Regarding the onset of the headache on the left side, it was of a sudden onset, and it was a new headache. The patient didn't experience this headache before. The left periauricular or jaw pain and the neck pain that radiates to the left arm were of a slow onset. The location of the headache was in the left temporal region. The facial pain were in the left TMJ, around the ear, periauricular, and the arm pain were along the entire length of the left arm. The neck pain radiated to the arm on the same side, and the changes in vision were in his left eye. Regarding the chronicity of the temporal pain, it was, and the vision changes were acute, so it was sudden. The neck and arm pains were progressive and chronic. Regarding the frequency and duration, the temporal pain was continuous, unrelenting. The TMJ and ear pain were intermittent and provoked with function by chewing. The neck pain and the radiating pain occurred intermittently and multiple times a day. Regarding the intensity of the temporal headache, it was 5 out of 10 in the visual analog scale. The TMJ and ear pain were moderate. The neck pain was mild, and it radiates also to the ipsilateral arm. So this is the visual analog scale. It is used commonly in non-odontogenic facial pain conditions for the patient to determine their level of pain, so they will point at the site where it coincides with their level of pain. It's also usually used in orofacial pain research. Continuing with our history of present illness, the quality of the temporal headache was of a throbbing nature, whereas the TMJ, ear, and neck pain were dull, achy. The aggravating factor for the temporal TMJ and ear pain is chewing. The neck and arm pain were aggravated by neck movement. Relieving factor, there was no relieving factor for the temporal pain. It was unrelenting, whereas the TMJ, ear, neck, and arm pains were relieved by rest. Regarding response to past treatment, none of the past treatment tried achieved pain relief for this patient. And because of the nature of the pain that radiates to the left arm and to the left jaw, they did a cardiac enzyme assay, and it was all within normal limits. Associated factors, claudication during chewing. Claudication is a jaw pain while functioning, and it is a different type of pain. It's different than a muscle type of pain because it's usually caused by fatigue of the muscle due to lack of blood supply. And also he experienced paresthesia in the neck and arm during the neck movement, blurred vision, and scalp tenderness while palpation. The referred pain, yes, there was a referred pain to the neck. The jaw pain referred to the neck, the arms, and the side of the head of the same side, on the left side, and the left neck pain radiated to the same arm. The patient also reported poor quality of sleep. He can fall asleep, but the duration and the quality or the depth of sleep was affected. So regarding the patient's medical history, he's a known diabetic, type 2. He has also hypertension and hyperlipidemia. So he's on anti-diabetic medication and angiotensin receptor enzyme antagonists for the hypertension and also statins for the hyperlipidemia. Regarding the social history, he was non-smoker, no alcohol use, no recreational drug use, and he is a retired Marine officer. Regarding the physical exam, everything extraorally and intraorally were within normal limits. Because of the jaw complaint, we did a TMJ focus exam. Regarding the mandibular movement, it was within normal limits, but with pain, especially when turning to the left side. And the cervical or the neck movement also restricted with moderate pain. When we palpated major muscles of mastication like temporalis and masseter, it was severely tender on the left side and reproduced 70% of the patient's familiar pain. Familiar pain is a term that is commonly used in non-odontogenic orofacial pain conditions. It just means that when we do the examination and we palpate an area, this area can have the same pain that the patient is experiencing. So this is a familiar pain. When we palpated the neck, especially the sternocleidomastoid muscle, it was moderately tender on the left side and producing a familiar pain by 50%. The temporal artery on the left side appeared tortuous, but we can feel a pulse in that area. When we palpated the joint itself in the periauricular area, it was mildly tender on the left side. This is the clinical picture of the patient. You can see the temporal artery, tortuous, bulbous, but there was a faint pulse when we did the palpation. So our assessment, now that we did a good history taking and clinical examination with the patient, is to rule out a serious condition with a serious complication called giant cell arthritis. We also want to, of course, the patient has a myofascial pain because he has tenderness of the muscles of mastication, cervicalgia, he has neck pain, and also we want to rule out strokes, cerebrovascular accident, and because of the patient's history of diabetes, we want to rule out retinopathy causing the visual changes. So because we are scared of giant cell arthritis, and we will talk about this condition, we directly prescribed high dose of prednisolone, which is corticosteroids, for 2 weeks. And at the same time, we did some labs. Glycosylated hemoglobin, it was within normal limits. Erythrocyte sedimentation rate, the normal is 0 to 15. For this patient, it's almost 100. Erythrocyte sedimentation rate, or sometimes called SED rate, do you know what it is? It's basically when you have inflammation in your body, there is cytokines or proteins produced. These proteins will cause RBCs to stick together. And when they do that, they will be heavier and they will settle fast. So the faster the settle is, the more the inflammation we have. Also, we have another marker for inflammation, which is C-reactive protein, and it is also elevated markedly in this patient. So definitely, there is an inflammatory process going on. So because of the risk of giant cell arthritis, we referred the patient to neurosurgery. They did an MRI of the brain and MR angiogram to rule out any strokes or any problems with the neck vessels. And everything was within normal limits. Then they did a biopsy of the left temporal artery. I will not go in depth in histopathology, but there's 2 things you have to know about, which is something called Monckeberg medial sclerosis. It's similar to atherosclerosis, but instead of lipid deposits, we have calcium deposits. So it's a kind of dystrophic calcification. And it was found in this specimen in the tunica media, together with multinucleated giant cells forming granulomas in the tunica media. So these 2 things are confirmatory for giant cell arthritis. And this is the Monckeberg calcification here in this area. You can notice the narrowing of the lumen. And this is the giant cell formation, or the multinucleated giant cells. So what is giant cell arthritis? It's a granulomatous inflammation that resulted in an arthritis of the medium size and large blood vessels, with great predisposition to cranial arteries, especially temporal nerves, temporal artery. And this is the American College of Rheumatology definition. So the classification criteria by the ACR, you have to have at least 3 or more of the 5 criteria. The 5 criteria include an age above 50 years old, an elevated erythrocyte sedimentation rate, a new headache in the temporal area with reduced pulsation, tenderness of the temporal artery. Although typically you will feel pulsation and throbbing, it may decrease to a point you will not feel anything. So as the disease progresses, we will have more granulation tissue, more narrowing of the lumen of the artery, and eventually we will have complete blockage and loss of pulsation. Another criteria is, of course, biopsy showing the previous characteristics. We have also additional criteria by the ACR, which is claudication of the tongue, painful movement, the jaw, and also upon swallowing, scalp tenderness. So regarding the epidemiology of GCA, the incidence, which reflects the number of existing cases, is about 10 to 20 in 100,000, whereas the prevalence that reflects the number of new cases was about 50 cases in every 100,000. It's more common in females than males, and the peak incidence is above 70 years. And about 2/3 of the patients will develop ocular symptoms, and up to 30% will have permanent visual loss. That's why we reacted fast when we suspected giant cell arthritis, even before we have the confirmatory diagnosis because of the risk of blindness. So the last